today we are very fortunate to have with us Dr. Niam Akhtar of the clinical support team of the NHS Blood and Transplant. Naim's background is as a consultant haematologist, but he now works for the blood transfusion service. Over to you, Naim.
Thank you ever so much. Can I express my thanks to the Society and for inviting me? So I'm here, don't all shout at me once, I'm here on behalf of the National Blood Service. It's called NHS Blood and Transplant, and so as Howard has already expressed, you know, it's obvious treating patients with hemochromatosis that we have this valuable resource of blood, and surely this can be used in patients, because there's no reason why there's nothing wrong with the blood from hemochromatosis patients. We all know that. So why can't it be readily used, and why can't there be blood donors? So just to give you a little bit of context, because I've been associated with NHS Blood and Transplant just over a year now, just to give you a bit of context of how they operate, which might help to understand their perspective. So NHS Blood and Transplant, we're the English blood service. So Scotland have their own, Northern Ireland have their own, and Wales recently have declared UDI and have their own service as well from the English. So I'm talking about the English blood service essentially. And we operate under legal regulations which are called the Blood Safety and Quality Regulations 2005, which were originally imported from Europe. I don't know what's going to happen post-Brexit, but they're currently how we operate, but we also have a standing parliamentary committee to oversee us. So in terms of just simplicity, we actually operate on the basis of providing the safest blood for our patients as possible. So that's our number one issue. The second issue is that we have a duty of care for our donors and the welfare of our donors. So the second issue that we have is make sure that our donors have no coexisting illnesses, they're fit and well, and that we don't cause them any harm as a result of the donation process. So that's the second duty of care that we have. The third duty of care that we have is to our staff, to make sure we don't expose them as a result of taking blood donation collection. We don't expose them to any harm, health and safety, and all that sort of. And the fourth parameter that we have to operate within legal guidance. So it states that, you know, we'll be prosecuted if we accepted somebody under 17, for instance, or if we accepted somebody over 70. So we have to operate under certain legal. So that's how we operate, and that's the context. And so just to give you a parameter, and I think, to be fair, I've had an opportunity just to review what's been happening to patients with genetic hemochromatosis who wish to become blood donors. And I'll give you a brief review about that. And I think it's fair to say on both sides that there have been issues about how we induct patients as donors. One of the underlying principles about blood donation in this country is that it's considered to be freely, you know, voluntarily donated, informed consent, and there's no exchange of money or gifts or anything like that. So it's purely voluntary act. And there should be no gain by the donor in terms of blood donation. It's slightly different, I suppose, if you analyse it for hemochromatosis patients, because you have a need, if you like, to donate blood, whereas the vast majority of donors, they don't have a need, they just voluntarily give blood. So just bear that in mind. So in terms of how do we deal with hemochromatosis donors? So at the moment, I have to be honest, it's fairly cumbersome and bureaucratic how currently we, if you like, in the process of taking on hemochromatosis donors. So the referrals can come from various sources. You can self-refer, your specialist team, or you go via your GP. Essentially, we have three layers, if you like, I shouldn't say that, but three layers of bureaucracy. So you've got a helpline number, a national helpline number, which is on the website, and you dial that, and you get put through to Belfast. And Belfast is our national contact centre, and they actually take your details. So they do the registration, if you like, and they take your details. And once you say hemochromatosis, they stop, and they say, right, okay, so we have to put you through to the referral team, which have a protocol based on a process on their computer, and they can take further details from you. So they put you through to Newcastle, where the referral team is. And the referral team will take your details down and register you. But with hemochromatosis, they're keen to know that, A, you're in maintenance phase, B, that you're free from any organ damage, and C, you're under a specialist team and you've got continued care for that team. And so as a result of that, they may put you directly through to us, or they seek advice from us. We're part of the clinical support team. We're a national team, but we're based in 5 sites. And we send you a pack. And what we send you is, we send you an information sheet, 935, which is about hemochromatosis, how the blood service deals with it. We send you 2 letters. One is addressed to you as a donor, potential donors, to say, you've got hemochromatosis, we'll welcome you as a donor, but you have to understand that you have to be in maintenance phase and fit and well and all that sort of thing. And the other letter is to your specialist or specialist team to let them know that your patient wishes to become a blood donor and that they have a continuing responsibility for the care of that patient. The 4th one is a double-sided donor consent form, and on one side, I can show you that in a minute. It asks you, whether you want to donate 12 weekly or more frequently than 12 weekly. Our current guidance is that male donors can donate 12 weekly. Female donors can donate 16 weekly. That's our current guidance, right, based on all donors. We've just completed an interval study where we looked at the safety of efficacy of donating more frequently than that, 8, 10, 12 weekly. But that will be published, and that's coming out soon. In terms of hemochromatosis donors, they have an option to be able to donate 6 weekly, 8 weekly, 10 weekly, or 12 weekly. So that's asked for in that form. And then you go through this arduous process of booking an appointment. And what my feedback has been from hemochromatosis patients is the fact that if you're a regular donor who can donate more than 12 weekly, and you're compliant with the 12 weekly or less frequent than that, then you're treated like any other regular donor. You can book online, you can book on the web, you can go to a fixed site, you can go to a mobile site. So there's no issue there. Unfortunately, if you happen to be requiring more frequent donations, then you fall under the HAE code, which case you have to ring up 2 weeks before, the helpline number, the same number, book an appointment at a fixed site, and that causes problems. So that is the current process at the moment. And so this is just for people who don't know it, but you may well be familiar with this form that you initially had to complete. So it's a fairly simple form, just ask for your demographic details, but this is the interval. So it does ask you that you can select this box in consultation with your specialist. So you can donate 6 weekly or a minimum, or 12 weekly. And then if you tick this box, then essentially you're ticking that you're just donating as any other regular donor. So it just asks you to understand that we collect blood for the benefit of patients. That's our parameter. And the hemochromatosis condition still remains primarily the monitoring of it, responsibility of your specialist. And so essentially you're signing that consent form. And on the other side, this is the form on the other side, which is for your specialist, which essentially, it's a bit like, it's confirming that the patient does have genetic hemochromatosis, because obviously if iron load for various other reasons, they're not indicated for blood donation. So if you've got iron overload as a result of other medical conditions, then that's a contraindication. You have to be in the maintenance phase. This is the English. I know in Ireland somebody might raise that. They do the de-ironing phase as well, but in the English service we only accept donors in the maintenance phase. You haven't got any significant complications as a result of hemochromatosis, and you haven't had chelation therapy, and you've not had any adverse reactions to venesection. And then you just sign that and send it back. And when you sign that and send it back, then we get you onto the program. So that's essentially how it works. So at the moment, the blood service wants to just be clear about why its perspective about what we can and what we cannot do. So just to put it into context again, so we process roughly about 2 million donations, and we take that from about 1.8 million donors. So it's a national big ask, if you like, and we have 5 processing units across the country. And you can imagine that everything is almost automated in terms of what we do to the blood to ensure its safety, to ensure that it's fit for purpose, etc. So, for instance, all the viral screens that we do, HIV, hepatitis, malaria, all those are essentially automated. People have always asked me this: why can't you just slip in a ferritin for us? Because it'd be great if you could tell us what the ferritin is as well. It's physically impossible because we'd have to do it for everybody. The process is such, it's automated, it's driven such that we'd have to do it for 2 million donations, and that's not appropriate or cost effective. So we operate on that kind of level. So that's why we just stipulate that we collect. Essentially, our service is to collect blood for the benefit of patients. We're absolutely happy to accept individuals with genetic hemochromatosis, as we accept anybody who wishes to donate blood. So we don't make any great distinction about that. Unfortunately, currently, the system is that if you want to donate more frequently than 12 weekly, you have to go to a fixed donation site, and you have to make this appointment by ringing the number 2 weeks in advance. And we cannot provide iron monitoring for you, or we cannot provide bespoke phlebotomy. So if suddenly you feel your ferritin's gone up and you've already donated, and you feel that perhaps you need another donation, we would advise you to seek medical advice for that, because there may be other reasons. So we're not experts in hemochromatosis, so we would defer that to other people. And we certainly can't provide you advice on your condition in terms of hemochromatosis. So you still have to comply with what we call the donor health check. So the donor health check is a questionnaire about lifestyle, illnesses, medication, travel, sexual orientation, activities. So every donor has to go through that donor health check as well. So obviously everybody complies with that. That's just reiterating some of the similar issues before. So this might be of interest to you. So when we looked at, our systems are automated. So we've had this system called Pulse, which is our automated system for managing all donors across nationally. And when I looked at how many hemochromatosis donors have we on the system, so initially I found 219 so-called expressions of interest, I've labelled it, which means that 2019 individuals approached the National Blood Service and said, we wish to become blood donors. So that's how we get that number. And how did I interrogate the system to get that number? Well, I based it on the number of packs or letters that we sent out, because initially, when they make the initial contact, the first thing we do is we send them an information pack, say this is how we operate. So that was based on that. But in actual fact, if you look, significantly less than that were returned, and a large minority, 40%, never got to the stage of blood donation. So despite the fact that they were supposedly in maintenance phase, they wanted to donate blood, we sent them the packs, but for some reason they never got to their first donation. So that's something worth investigating further. It's the obvious age bands that we expect, and the other thing that I just wanted to highlight is the fact that the very vast majority, 97%, actually were on the so-called whole blood code, which is just treated like any other blood donor. So they were on 12 weekly or less frequent than 12 weekly donations, and they had the option of booking themselves online, fixed or mobile sites. They had all those options. They just treated like any other blood donor. And that means that they were donating 4 donations, on average, about 4 donations a year. And only 3% actually fell into that group. who had the so-called HAE code, which meant that they wished to donate more frequently than the 12 weekly. So if we just look at that, group now, this is the group of 59 donors who are in the HAE code. This is our 3% population. So if we analyse, so it's not very good reading actually. If you look at that, it's not very encouraging, is it? Because if I just go through it, of those 59, only 7 were actually active in terms of blood donation. So, and if you look at those individuals, so 1 was donating 6 weekly, 1 was donating 8 weekly, 1 was donating 10 weekly, and four individuals have just given single donations. The records being deleted, so the records get deleted if they don't attend. So if they don't attend 3 consecutive appointments, or they don't phone up to say they wish to have another appointment. So, and 1 was deemed, I suppose, medical reasons. So the blood service still reserves a right for all donors to look at their veins, and if they feel they're going to cause them a bit of torture, because our needles are quite chunky for blood donation. So obviously sometimes the nurses make that assessment based on their veins and say, sorry, we think you'd be great, but we're not prepared to take that risk with you. So one of those individuals, 30 of them were enrolled. Again, large DNA and no appointment. No appointment was made. 16 were withdrawn. So we get withdrawal for various reasons. And one of the things that we do in the clinical support team is actually encourage even our regular donors to withdraw when they don't actually want to withdraw, on the basis of their medical conditions, because they want to reach some milestone in their donation history. We say, sorry, we can't, because your welfare is also of paramount importance. So if it puts you at risk, we're not prepared to take that risk on your behalf. So you have things like medical conditions. So 11 had medical conditions. Syphilis is a no-no, so anybody who develops syphilis at any time, I'm afraid, is taken out of the circle. There were a couple of skin issues, and particularly if the skin issues affect areas where we're likely to stick needles in, obviously it's not appropriate. Make that worse. 4 had neurological conditions, 3 had malignancies, 1 cardiovascular. So these are the type of withdrawals that we do. So sometimes when we say MCP, that means medical correspondence. So medical correspondence means that we've sent out the pack, we've asked the donors, please can you send it back to us, the form 4058, and they haven't. And so the MCP code remains there until we get the letter back. When we get the letter back, then we say, fine, thank you very much, you can proceed. So for some reason, it got locked in the system. TDW stands for anybody who's had a blood transfusion post-1980. It's another contraindication. So if you've had a blood transfusion for whatever reason, you cannot become a blood donor. 1 was age retired, and 1 was at donor's request. So these are the frequent donors. So at the moment, before I come into that, so at the moment, it's not a pretty picture in terms of, I mean, when I was asked to review this, it came as a bit of a shock. It's not a pretty picture in terms of how we're inducting individuals who wish to become blood donors, and we could use their blood. Yeah, the other thing to just say about blood, I discussed it yesterday, but I haven't put those slides in today, is just to give you the perspective that we need roughly 200,000 blood donors every year. New donors to recruit to replace currently donors which are retiring for their own volition, retiring on medical grounds, or just want to stop, or have moved, so whatever reason. So we still need to. So in terms of hemochromatosis donors, you're an ideal population in terms of blood donation, because you're a relatively middle-aged group who have got a requirement to donate blood, and so fairly stable population. So you would be ideal. But generally, we have a due requirement to accept those donors, but at the moment, that's the other issue. The other issue I just want to mention is the fact that we're moving to a system now where, I'll come to that. So this slide is slightly out of order. So I'll put this down first and we can discuss it. So one of the discussions that we've been having at NHS Blood and Transport is how do we make the process a bit more refined, a bit more user-friendly, so that you don't have to go through this bureaucratic process where you need signatures from your specialist to get induction. So one of the proposals is, at the moment, welcome your feedback about how this would work, because this is being put to our management as well, so to get final approval. So before they also need to approve it. So essentially, anybody with a donor with hemochromatosis, genetic hemochromatosis, so currently you contact a helpline number, so a national helpline number. That's or you can attend a session. That's fine. You can still continue to do that because all donors have to be registered. So you still need, every single donor still needs to contact the National Contact Centre, because you need to be registered in terms of your demographics, your age, all that sort of thing. So you need to have a unique number, so for us to process it. So that's fair enough. Everybody has to go through that process. So what we're suggesting is that we're a clinical support team is a national team based in Bristol, Newcastle, Manchester, London, in 5 sites, and we operate on a 24/7 basis as well. So generally what tends to happen is once you're registered, they contact us and say, in terms of somebody's suitability. Historically, what we've been doing is sending you out a pack and saying, can you complete this first? So what the proposal is at the moment is that we accept you by default, and you say, just confirm to us that you're in maintenance phase. Obviously, if you're not in maintenance phase, then we say, sorry, can you come back to us when your condition is a bit more stable or you're in maintenance phase? If you are in maintenance phase, just confirm that you haven't got any issues with your health, generally. And then also, if you haven't got any issues with your health, then you're already registered there, and then we just accept you. And then you can give us the contact details of your referring doctor when you come at session, so that we got it on the record if we need to contact anybody about your condition. Otherwise, we just take you through like any other regular donor. But obviously, if you've got any medical issues, then we have to withdraw you. So that's what's been proposed at the moment. This is the other thing I just wanted to highlight, and I highlighted it yesterday, is just to give you a view about how the service is changing, how the blood service is changing, and they may reflect on how you're approached, but how every donor is approached. It's not peculiar to hemochromatosis donors. So at the moment, if you look at this is the UK population in terms of predominantly North European population of blood donors, in terms of percentage, what blood groups they have. This is what our demand is for whole blood, and this is what our demand is. This is how we try and match the donors to our demand. And this is platelets, and what our demand is, and how we match the donors. So just to highlight with a few circles, just to see some discrepancies there. So if you look at that, for instance, A negative, we only have 7%, but we have a huge requirement for, these are universal platelet donors, so we have a huge requirement for platelets. So we're having lots of A negative donors, giving us red blood cells, but we're only using their platelets, so we're having too many red blood cells, if you like, and some of that is going to waste potentially, and we want to reduce that. O positive is fairly common, and so we don't require so many O positive. A positive is fairly common, so that's okay. O negative, as you probably know, is a universal. So if you're O negative, we need a lot of your blood, but not so much platelets. So we're trying to match what your blood group is as donors as a whole to what we require, rather than historically what we've done is we've just welcomed all donors, collected their blood, put it on the shelf, and hoped that we'd use it. And when we didn't use it, it was wasted. Just like you're aghast that your blood is wasted when it's not venesection, in the blood service, we're also trying to address the issue that our blood is being wasted if we don't use it, if we don't collect the right type of blood from the right donors. Because ultimately what's driving us is what the patients require in terms of what they require. So this is just to give you an overall picture about the common blood groups, this is predominantly in the North European population. And this is where the blood is going, in essence, just for information. A lot of it goes to people in anemia, orthopedic surgery, hematology. We're guilty of using a lot of our own products, people with bleeding disorders. And so in trauma, you can use vast amounts of blood, potentially. Just want to highlight the concept, again, what I've said. This is so-called the pool system now. So what we're highlighting now is that rather than collect blood from all donors, put it on the shelf and hope that it gets used, and if it doesn't get used, it gets expired, we just dump it and it's incinerated. Well, it's such a waste, isn't it? We've gone to the expense, the donors have given up their time to donate blood, we've processed it, it costs us so much money to process it, we put it on the shelf and it doesn't get used. So that doesn't really make much sense. So we're trying to reduce that wastage by getting information from our patients about the type of blood that they require. What blood group do they require on a regular basis by a trend analysis and whatever. And we're trying to inform, we're getting information from the patients via the hospitals, which informs our stock holding units, which then informs our manufacturing sites to process what kind of blood that they need to process. Which then informs our collection teams of what to go and collect, which is then going to inform of which donors we're going to invite each demographic area to come and donate blood. So this is going to happen for all donors. So even though donors want to donate blood, we're going to say to them, actually, we need your blood, but actually we need your blood less frequently, perhaps once a year, but somebody else who might be O negative, we want your blood 6 times a year. So it's going to dictate. So to summarize, collection is going to be pulled in the future by the manufacturing demand. So we're going to try and have our donors aligned to the collection targets, and geography depends on what blood group they have. We have to have a good communications with them to make sure we don't put them off donating blood. We want to make sure ultimately that their gift of donated blood is used ultimately, but that does have an impact because donors generally will not be able to donate, when they feel they wish to donate. This just summarizes the same thing again, I think. So I'm happy to take any questions. Thank you very much. Sorry, have I gone on over time?
We are a bit short of time, but perhaps take one question.
Right.
Okay, gentleman at the front here, put his hand up. You're the lucky man. Make it a good one.
What was the question? I do donate.
Good.
I'm O negative in maintenance. I'm 68, coming up to. Can I continue after age 70?
Yeah. So once you've continued, so our criteria are, if you started before 70, you can continue. And if you wish to start before 70 and you haven't donated before, we accept your venesection as a blood donation.
Okay. Can I have another one? Sorry. In Buckinghamshire, where I live,
Right.
it seems they've reduced the blood collection teams by 1.
Right.
So actually I have at times found it difficult to get fitted in, even though I need to be fitted in about every 12 weeks.
Sure.
Is there any reason for that stopping one team or disbanding one team?
So I'm a clinician, I'm not into management, I can't tell you about the whole processing, but they are trying to look at teams all the time to seeing where the donors are and what the most effective teams are, and they all have collection targets. So if they don't meet their targets, there's various reasons. I can't, that specifically, I might have to take it back. Yeah, thank you very much.